Okay, hello and welcome everyone to tonight's webinar, the first of two webinars on menopause management, brought to you by the Capital Health Network and menopause experts from Sexual Health and Family Planning ACT. Tonight's webinar focuses on menopausal hormonal therapy. The second webinar, which will occur in the first quarter of 2024, will focus on non-hormonal options and lifestyle optimization. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. I pay my respects to their elders past, present and emerging, and I'd also like to acknowledge and welcome any other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and never has been ceded. I would also like to acknowledge the call for a week of silence to allow for reflection on past events. I am Dr. Leonie Harcourt, the GP advisor at Capital Health Network. Also with me tonight is Dr. Clare Holberton and Dr. Tara Frommer from Sexual Health and Family Planning ACT. And also, these webinars could not happen without the wonderful Kanal Mohiti from Capital Health Network. So onto the housekeeping bit of the webinar. All participants have been muted. Please, if you've got any questions, and we do love questions, type them into the Q&A section on your Zoom screen, not into the chat box. So the Q&A section. And we will have a question and answer session at the end of the presentation. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with any of your networks or to have a look at it again if you need to pick up any bits you may have missed. Regarding CPD, please fill out the post-event evaluation survey. Kanal will send that out to you, and then we can email you, or Capital Health Network will email you a certificate of attendance after the event. And please feel free to report 1.5 hours of educational activities to your CPD home. So another thing we'd like to mention is before we start, we'd like to highlight a very useful resource, and that's the Health Pathways website on menopause. And the login for the Health Pathways, if you haven't looked at it, so type in Health Pathways into your search engine, and the login is together, all lowercase. And the password is for health, FORHEALTH, all lowercase. Health Pathways is a great source of up-to-date clinical and referral information, and it's localized to the current area. And it's a design collaboration between GPs and all areas of the health system. So the Health Pathways team always values feedback. So if you want to give them some feedback, improvements, things you think are great, or further health pathways that need to be developed, there's a feedback tab at the bottom of every pathway. Our first speaker tonight is Dr. Clare Holberton. Clare is a senior medical officer at the Sexual Health and Family Planning ACT, where she works with Dr. Rosa O'Kane and Dr. Tara Frommer at the Canberra Menopause Centre. Clare enjoys being part of a team dedicated to offering information, support and treatment to women going through menopause transition. She's been a member of the Australian Menopause Society for the past 12 years, and she's happy to receive emails or calls from GPs to discuss menopause care. That's very generous of you, Clare. When she's not at work, she enjoys bushwalks, dancing and swimming. So thank you very much, and over to you, Clare.
Thank you very much, Leonie, and it's a real delight for us to be here this evening, and really appreciate the fact that you've given up your Thursday evening to join us. And before starting the presentation, I just wanted to acknowledge that there will be some individuals going through the menopause who don't identify as women, but throughout this presentation, we are referring to women and using she, her pronouns. So what we hope by the end of the evening is that you'll feel confident about detecting perimenopausal and postmenopausal symptoms in your patients, that you'll have some sense of the time frame that these symptoms occur over, and that you have an approach to discussing patients' menopause hormone therapy with your patients, and know how to prescribe it safely. So when we're talking about menopause, menopause itself is just the day that a woman has her final period, but we only say that someone has reached the menopause when it's been more than a year since that last period. Quite often women will have gaps of 8, 9, 10 months without a period and then bleed again. And so they need to start counting from that, subsequent bleed. The other thing to note is that a lot of things that we do as clinicians can mask the menopause. So hormonal contraception, things like endometrial ablations or hysterectomies mean that that marker of the final period is absent for women. So the typical age for menopause is anywhere between the age of 45 and 55, and the average age in Australia is about 51. But there are ethnic differences in that age and also in the symptom profile. So women from South Asia, from Sri Lanka, India, Pakistan, Bangladesh, often go through a menopause earlier. So their final period is on average around the age of 46, 47. And what it signifies is that the ovaries have ceased to function, and as a result, estrogen levels are really falling for women. But most of the symptoms that you'll be presented with are actually occurring much earlier than that 51 age. So most women that are having symptoms will develop symptoms within the perimenopause, which just means that time around the menopause, which is quite a nebulous concept. And so one of the things that I hope you take away from this presentation is the idea that the menopause transition or the perimenopause begins when there's a change in cycle length such that 2 consecutive cycles are either a week shorter or a week longer than a woman's normal regular cycle. And this was brought home to me very recently in the clinic, where I had a patient who had ticked that her cycles were regular, but she had a lot of perimenopausal symptoms. She was getting hot flushes and sleep disturbance. And when I teased out her symptoms and her menstrual cycle, she said for the past 2.5 decades, she'd had a 35-day regular cycle, and now her cycle had shortened to 24 days. Still reasonably regular, but definitely in that perimenopause. So it is really important that you take a good menstrual history. If someone has their final period before the age of 40, we regard that as an early menopause, and that occurs about 12% of women. And if the final period is before the age of 40, which occurs in about 1% of women, then we talk about premature ovarian insufficiency. And with these women, particularly those women that have POI, we know that they are at increased risk of cardiovascular disease, of osteoporosis and fracture, but also at increased risk of dementia. So for this group of women in particular, hormone therapy is really beneficial at reducing those risks. The other thing is we are seeing more patients, particularly those women that are choosing to have risk reduction surgery, so are having their ovaries removed to reduce ovarian cancer risk, going through an early menopause also. But another thing to really take home is the fact that you don't need a hormone level for the vast majority of women to diagnose the perimenopause or menopause. You just need a really, really good history. And one of the things I think it's important to be aware of is that as we age, we have really increased the amount of time that women are spending in the postmenopausal phase of their life. So in the early 1900s, a woman would spend about 4 or 5 years in that postmenopausal period before they died. But now someone who is born in 2020 can be expected to live to their mid-80s, and so over 1/3 of their life is spent in that postmenopausal phase, and it's really important that we optimise women's health to deal with this. Now, this is a very busy table, and I won't spend a lot of time on it, but the Stages of Aging Reproductive Workshop was first held back in 2001. And the idea behind it was that there needed to be clarity around the language used around reproductive health. The term perimenopause was very nebulous. And what the people that introduced this stages of reproductive aging were hoping was that it would be similar to the Tanner scale that we use for puberty maturation, so that we can have something that will guide both research but also our clinical decision making. Now, the part in red, I'm just going to hone down into in a little bit more detail on the next slide. So, as you can see at the top of the slide, what the key marker is that final menstrual period. And as I mentioned before, the perimenopause starts with that change in the menstrual cycle. A slightly cleaner term is to talk about the menopause transition, which we divide into early and late. And it's often in this early phase where women will present to you. And it may be they are presenting with changes in their bleeding, so there may be variations in the cycle length, or particularly women present with really heavy bleeding. Another really common symptom in this early menopause transition is worsening premenstrual symptoms. So women who've never had PMS are now developing it, or women that have had PMS or PMDD are experiencing much more severe symptoms. Migraine also often worsens around this time with hormone fluctuations. And mood was also adversely affected. And a lot of women describe an irritability and rage, but other women will describe symptoms of depression and anxiety. Another really common and concerning symptom for women is that of brain fog, and particularly verbal memory being affected at this time. And often this occurs at the same time where women are taking on more responsibility at work and find this a very disabling symptom for them. And about 40% of women in the perimenopause will report musculoskeletal pain, and also sort of stiffness. And women that are athletic often report that they have more injuries around this time. And then as women progress on the menopause journey and periods start to spread out and eventually stop, that's when more of the vasomotor symptoms, the typical hot flushes and night sweats and sleep disturbance, come to the fore. And then over time, most of the menopausal symptoms do improve. The exception to that are the genitourinary symptoms, so particularly the symptoms of vaginal dryness, painful sex, sort of increasing urinary symptoms, are symptoms that tend to progress with time. So those symptoms don't improve, but most of the symptoms that women will experience in the perimenopause and early menopause do improve with time. And I think it's reassuring for women to know that that will occur. What they don't like hearing is that the average duration for symptoms in Australia is about 7 years. And then in the late postmenopause, the issues around heart health and bone health come to the fore for women. Now, there are exceptions to this STRAW criteria, and one of the things that you will get is after the webinar, when you get that survey from CHN, we've put in a whole lot of PDFs that have different resources, and this slide will be included on that, which will include the situations where the straw can't be used, but one of the common ones is if someone's using hormonal contraception or has had a hysterectomy. So but the only thing I haven't mentioned about this are issues around libido and also changes in fat distribution. So menopause itself doesn't cause weight gain, but a low estrogen does cause an accumulation of central body fat, and this can be a real source of distress for a number of patients. Included in your resources is this information graphic that comes from the Australasian Menopause Society. They have a lot of really great patient resources for you. So I would certainly highly recommend that website. The other thing I'd recommend is using a symptom score chart, and we'll include this also. What I like about this chart is it groups the symptoms into different areas. So the top covers sort of more of the vasomotor symptoms, then we have mood symptoms, the musculoskeletal symptoms, and those associated with genitourinary symptoms. And women will score this from 0 to 3, and a quick glance at this will help you focus your consultation onto those symptoms that are of greater concern for the patient. The other thing that just came through today actually is the New South Wales Health seems to have discovered the menopause just recently, and they have produced a symptom score checklist similar to this, not exactly the same, but they have it in 8 different languages and an easy English resource as well. So, as I said at the start, you don't need a blood test if the woman is over the age of 45. They're really not accurate. As you can see on the graph, estrogen fluctuates really wildly, and the diagnosis of menopause is usually made when the FSH level is over 30, but a woman could be having symptoms for 4 or 5 years before that FSH rises. So unless there's an indication to do an FSH level, just listen to the patient's history and make a decision for treatment based on that. The exception are those younger women and also those women that are using a progestogen-only form of contraception that you're not sure whether or not it's safe to stop contraception. So moving on to hormone therapy, there's a lot available, and what I would suggest is you become familiar with just a couple and comfortable with prescribing them, and then have sort of ways of tweaking your management if you need to. And so the reasons you would prescribe hormone therapy is that we do know it is the most effective treatment for menopausal symptoms. So it's about 90 to 95% effective. It also has significant health benefits, particularly around reducing osteoporosis risk. And this benefit is about the same as the anti-absorptive therapies. And as I mentioned earlier, it is really, really important for those women that go through menopause early that we give hormone therapy to reduce those long-term health risks. But hormone therapy should just fit into part of really good midlife care for your patients. When to start hormone therapy? So we initiate hormone therapy for symptoms, and we know that the risks are minimal if we start it within 10 years of the final menstrual period or before the age of 60. But there are contraindications. The big one is breast cancer. Another one is a estrogen-dependent malignancy. So if someone has abnormal bleeding, it is really, really vital that you sort that out before starting hormone therapy. The last thing you want to do is give estrogen to a woman who has endometrial hyperplasia or precancerous lesions. Current thromboembolus and severe cardiovascular disease are contraindications. If your patient is hypertensive, it is really important you get the hypertension under control before starting hormone therapy. But if you've managed to control the hypertension well, there's no reason to withhold hormone therapy from that patient. But there are a group of women who, either because of their family history or their personal history of friends or family who've had breast cancer, or who've had a poor experience with hormone contraception in the past, who will choose not to have hormone therapy. And it's important with these women to say that there are alternatives available, and our second webinar will deal with that in more detail. When prescribing, essentially you just need to ask yourself 3 questions in order to be able to prescribe safely. The first question is, does the patient have a uterus? And if the answer to that is yes, then you need to prescribe estrogen for symptom control and a progestogen to keep them safe. So when hormone therapy was first introduced in the US, estrogen only was prescribed. And this was done through the 50s and the 60s. And then in the mid-70s, it was discovered that there was about a 4- to 5-fold increase in endometrial cancer in those patients that had just unopposed estrogen for their hormone therapy. So the progestogen component of hormone therapy is given to keep the lining of the womb thin and prevent endometrial proliferation and cancer. So if a woman doesn't have a uterus, all she needs is estrogen alone for her menopausal symptoms. The only exception to that is if a woman has a history of severe endometriosis. If you give estrogen alone to those patients, there's about a 3% risk that you will reactivate any pockets of endometriosis that are still in the pelvis, and about a 1% risk that those pockets of endometriosis may become malignant. But in general, if a woman has had a hysterectomy, she only needs estrogen. If she's had an endometrial ablation, she also needs progestogen to protect any areas of the endometrium that are still there. The second question you need to focus on is the time from the last period. And if it's less than 12 months, we need to use hormone therapy in a cyclical regime. So this way you give estrogen all the time, and for 10 to 14 days each month, a progestogen is added. The reason we do this is we give both hormones all the time and women are still occasionally cycling. They will get abnormal bleeding, and you don't know if is that because there's some pathology going on or because of the hormone therapy that you've prescribed. But when you give a cyclical regime, you need to warn the woman that her periods are going to come back. The only way round that is to use a hormone-containing IUD, a Mirena, as your endometrial protection. If the patient is beyond a year since the final period, then we give both the estrogen and progestogen all the time. Now, you will see a number of patients whose only concerns are related to the genitourinary symptoms, and if that's the case, then vaginal estrogen is all they would need rather than systemic therapy. Now, this guide also you'll get a PDF of, and it's really useful because the Australasian Menopause Society update this regularly. It divides hormone therapy into low, medium, and high dose, and talks about which preparations are available, how they're actually given, and it also lists which are on the PBS and which aren't. So it is a really useful tool if you need to tweak your therapy. So when prescribing it's really important that you individualize your treatment, and the case studies, I hope, will show that to you. Starting at the and maintaining the lowest effective dose is really important. The risks are lower if we use a natural body identical estrogen and a progesterone. And risks are also lower if we give estrogen through the skin. The correct regime I've covered, and it's really important that you touch base with your patients to check how effective the treatment is and whether they've got any side effects. So the short-term side effects are quite similar to the pill, and usually settle within the first month or two. What's really important is that if a woman is bleeding on hormone therapy and she's been on that dose for more than 6 months, you really, really need to investigate it and make sure that there's no issue with the endometrium. The longer term consequences are thromboembolic disease and breast cancer, and we'll move on to that. So the risk of venous thromboembolism is low, but if oral hormone therapy, particularly conjugated equine estrogen, is used, then the increase in VTE risk is between 2 and 4 times. So it is important we assess women for risk factors for venous embolic events. And if risk factors are present, then it's important to use transdermal estrogen, because up to a moderate dose of 50 microgram patch, there's no increase in VTE risk. But someone who has a history of venous thrombus or a familial prothrombotic condition, usually I would be consulting with their hematologist and touching base with them that my planned therapy is acceptable to them. Breast cancer risk with hormone therapy is something that most women are aware of and are really concerned about. And I think it's really important as clinicians that we put this in context for our patients. And one of the tools I use for that is this graphic, which comes from UK data, which shows clearly that the vast majority of breast cancers occur because women are female and getting older. 2% of breast cancers that are attributable to lifestyle factors occur due to hormone therapy, but the far more significant lifestyle factors around weight and alcohol consumption. And people, when they see this graph, find it quite useful, I think, to help determine the risk. The other tool that we often use in the clinic is the Peter McCallum I Prevent a breast cancer risk assessment tool. And what I encourage women to do is to complete it as a baseline without ticking the hormone therapy box. So this woman did that. Her baseline risk was 92 in 1,000. And then she repeated it, adding in hormone therapy, which increased her risk by 11. And so that's around a 1% risk, which she found perfectly acceptable. Other women will find a 1% risk an unacceptable increase. But I think it really helps to give an idea that the vast majority of women will not get breast cancer. And although hormone therapy increases the risk of being diagnosed with breast cancer, it doesn't increase breast cancer mortality. And I think this is partly due to the fact that women who have taken or who are taking hormone therapy are aware of the breast cancer risk and are participating in their screening. The menopause consultation, there's a lot to cover, and I think it's really, really important that you set expectations. There's no way you can do a menopausal consultation in a short 10, 15-minute consult. But I think one of the important things is if a woman is presenting with these symptoms, that initially what she will want is for you to listen to her story and validate her symptoms. And if that in that first consultation you can get a good menstrual history and provide some information and resources and then get it back, is a really good strategy. This is another really useful tool. Again, we'll put it in the PDFs for you, again from the AMS. So if you have a patient who has booked in for a sort of short consultation wanting to talk menopause, I would send them home with this information, ask them to fill it in and bring it in back to the next consultation for you.
Thank you, Claire. So are we swapping over to Tara now?
We are, yes.
Okay, lovely. That was great, Claire. I've got lots of questions and I'm sure the audience does too, but we'll have to hold on. So our second speaker tonight is Tara Frommer. Tara is a GP and Senior Medical Officer at Sexual Health and Family Planning ACT. She feels privileged to be a part of the talented team that makes up the Canberra Menopause Centre here. She's passionate about empowering women in the menopausal transition through education and providing patient-centred, evidence-based care. When not at work, Tara enjoys being a mum and all things outdoors. So over to you, Tara. Thank you.
Thanks, Leonie. Okay, so thank you, Claire, for giving that really great introduction. And so my role today is, one, apparently to be the young person doing menopause, and two, to take you guys through some case studies, which I think is a really useful way to learn. So our first case study is Kate. And she's probably a pretty common presentation to most of us. So she's a 43-year-old. She's actually a single mum with teenage kids. She's got some pretty rubbish periods that are irregular and heavy. Her sleep is a bit rubbish, and she's complaining of feeling irritable and tired all the time. Probably quite understandably, having two teenage children, she does enjoy 2 glasses of wine on the weekend, but generally is pretty fit and well, is only very slightly overweight, has a bit of a family history of osteoporosis, and is pretty up to date with her current screening. She isn't currently sexually active, but she has recently started dating again, and is thinking about becoming sexually active. This is, I think, a really great infographic just trying to cover just how complicated our menopausal consults are. There's often a lot going on, and there's a lot going on for Kate. And trying to separate it out for us often can be really difficult. Often we've got, as Kate does, we've got adolescent kids, which are hard. As Claire was talking about, often these women are at a point in their career where they're kind of getting towards the peak of their career, and that can be really stressful. A lot of our patients are looking after elderly parents. And then we've got this kind of changing role, both, in the home, but also within society. A lot of women are talking about starting to feel invisible. They've got changes in their physical appearance, and that's affecting how they feel about themselves and sex and all of it. And us as practitioners, it can feel a little bit overwhelming trying to bring that all in together. But I think sometimes, like Claire was saying, actually just acknowledging that there is a lot that's going on right now, even just that validation really helps women. So coming back to Kate, and this is her menopause symptom scoring sheet. And so she's rating that irritability, that anxiety quite high, and that sleeplessness and tiredness, and a bit of muscle pains as well. I'd like to draw your attention to the fact, though, that she's not currently reporting hot flushes. And I guess this is probably a bit of a limitation of this scoring system. because actually, if you ask Kate a little bit more questioning about, how she's feeling around her sleep, actually what she does tell you is while she's not getting frank hot flushes, she is waking up quite a lot, feeling hot and sweaty, and she's struggling to get to sleep because she just feels uncomfortable. And she'll talk about the fact that, she feels like, and she's in the middle of Canberra in winter and she still has to throw off all the covers quite often, even though she's not getting that frank, drenching night sweats where she has to change the sheets. And obviously that temperature instability is actually quite common through this transition, and can cause a lot of issues with sleep and subsequent that domino effect of mood changes and cognitive changes as well. So coming back to the straw, and so this is where we think that Kate is. So she's starting to get a little bit of that variable cycle length, but we're not getting those really big gaps, and we're starting to get some of those early symptoms. So there's a lot to consider. And the big one, I guess, here is time management. For patients like Kate, we have the great luxury in the Menopause Centre of all of our first appointment patients are 45 minutes. And I know, because I also work in general practice, that that's not what you guys are getting. And so I think it's really important in that first consult, one, to do some validation and get out those most important concerns to the patient, but also to set expectations. And I do think I find that the menopausal transition is much better managed in longer appointments. And I find that patients end up a lot less frustrated. If you can sit down and actually get through a good chunk of stuff in an appointment, they walk away feeling much happier than kind of being sent away repeatedly. And so, in that first appointment, acknowledging that we do have some work to do, and that it might take a couple of long appointments, but we're looking to try and get her symptoms much better managed and her quality of life much better. Now, for Kate, she points out to us that, her top two concerns at the moment is the problematic bleeding. And she's also starting to be aware of the fact that yes, maybe starting on a new sexual relationship, she needs to start thinking about contraception and sexual health. And she is finding her teenage kids are whinging about her irritability. And probably what you're thinking about is actually now you need to start thinking about with Kate kind of that midlife health, that cardiovascular health and risk factors, and kind of lifestyle counselling as well. And so that might be on your list of things to do. And we've got to kind of mix together what obviously our priorities are in terms of health promotion, but also getting Kate's symptoms well managed. So actually, Kate was really organised, and this first appointment she's booked as a long appointment, so you do get to get through quite a lot of stuff. And so for Kate, particularly because she's had that change in bleeding pattern, she does need a pelvic ultrasound. And so you arrange that, as well as some basic bloods and some STI screening. Because you're really on the ball and you're really efficient, you do manage to go through her treatment options for heavy bleeding, at least the first line stuff in terms of anti-inflammatories and TXA. And you start having that conversation around what is menopause and safe sex and contraception. But most importantly, you give Kate some resources to go away and have a think about. And I think this is a really important part of managing menopause, is empowering these patients to make good decisions and try and navigate this in a way that's appropriate for them, because there's no one way of managing the transition for all of our patients. And the more that these patients are well educated, the better they do and the much happier they are. So for Kate, obviously contraception is an issue, and it actually often is for a lot of our patients. And I think it is really important to not make assumptions. And I know a lot of my patients come in telling me that they don't need contraception, and often that's just a lack of understanding that whilst they may have started to enter the menopausal transition, that does not guarantee that they cannot fall pregnant. And so discussing that with them, and and don't assume that Kate knows all about STI screening and prevention, having those conversations around it. And so just down the bottom here, this is our kind of takeaway point, and that it is really important. If you are under 50, it's 2 years after the last period that we should continue contraception for. And if our women over 50, it's 1 year after their last period. And so obviously in these patients, the risk of pregnancy is low, but the impact of unplanned pregnancy is really high. And maybe I see a slightly skewed population, but I would say at least a third of my unplanned pregnancies that present to me are patients over 40. And we know from the research that 1 in 4 of those pregnancies will end in abortion. Even for those women who do decide to continue the pregnancy, we are all aware of the risk of chromosomal abnormalities increasing, and also the risk to the mother themselves. There's this great guideline from the FSRH in the UK that covers contraception in this age group. And for those of you, and I haven't actually included the link here, but those of you that have a therapeutic guidelines subscription, they also have a little bit of a section on women over 40 and contraception. This is a really useful table to have available to you just to help remember when we can stop contraception. I will draw your attention to the fact that this table is focused specifically on contraception, and particularly for our patients that are using the Mirena for multiple reasons. So, for example, for using it for heavy periods or as part of their MHT, your decisions might be a little bit more individualised than this. And so as we talked about if you're not on any hormones, when you can stop contraception. I'll draw your attention to the fact that most people know that we don't recommend using the combined pill after 50. And we also do try and avoid using the Depo-Provera after 50. However, our other progesterone-only forms of contraception can be used over 50. And obviously, as Claire was mentioning before, they can mask when menopause occurs. And this is one of the few times that we do advocate using an FSH level. And so if you are over 50 and on one of these progesterone-only contraceptives and have amenorrhea with that, we usually suggest that you can do an FSH level. And if that is over 30, we would usually recommend discontinuing contraception after 1 more year. You also may be aware of the fact that there is good evidence for extended use of the Mirena for contraception in this age group. So if they are over 45 when their Mirena is inserted, it can remain in situ until 55, at which point for most patients we assume natural loss of fertility. Obviously that is different if they are using it for their MHT. So coming back to Kate, and she's gone and had her pelvic ultrasound, and that looks normal, which is great. She, unsurprisingly, has a low iron and is anemic with that, which I'm sure you're all very well versed in managing. And she's just a bit over it. She wants the bleeding sorted out, and she's ready to have some contraception, and she needs a mood and sleep sorted. Now, I'm just going to stop for a moment. And I was going to see if anyone had any suggestions at this point on what they wanted to do with Kate, but I don't know if we're able to do that on this system. Leonie?
Oh. No, actually, sorry, we're just kind of a Q&A typey system here.
Cool, that's okay.
Yep.
I just thought I'd double check. So I will keep going and not stop.
Yep, thanks.
That's okay. All right, so Claire has brought this up before, and this is a really helpful flowchart to have. So thanks, Claire, for writing it up for us. And so we're looking for Kate, and obviously she has her uterus intact. And so if we're thinking about using some hormones on her, and you know, that might be appropriate because like we were talking about before, she does have those low-grade vasomotor symptoms that are starting to affect sleep and mood. Then what we're looking at is a continuous estrogen and a cyclical progestogen. Now, obviously, for a patient like Kate, we've got a couple of other priorities as well. And so she's looking for a form of contraception, and we also need to manage her periods. And I think most people in this scenario are probably going to suggest to Kate that maybe the Mirena might be a good choice for her. And indeed, it is the only form of MHT on that list that is going to meet all of that criteria. Now, the Mirena isn't for everyone, and sometimes we do split apart those priorities and do them separately, but it is far neater to use the Mirena and add some estrogen on top of that, hence both managing her menopausal symptoms, her contraception, and her heavy bleeding all in one. Okay, so at the end of that consult, once again, you've been super efficient and you've organised for Kate to have a Mirena inserted. And you've also made a bit of a plan on once that Mirena is inserted, that she's going to start on some estradiol 25 microgram low dose patches. And you've also had a bit of a chance to just talk about the effects that sleep hygiene and exercise might have on her symptoms. And so Kate comes back at 3 months and she's super duper happy with you. She's feeling great. She is getting a little bit of spotting, but you warned her that might happen with the Mirena, so she's not super bothered by it. Her periods are so much better than they were before, and she's not having any side effects with the patches. Her sleep is much better, and as a result, she's far less irritable than she was before. You've had a chat to her about the fact that we will have to repeat her bloods and review her iron deficiency in a couple of months' time. Sorry. And she has started walking each day and being more active now that her sleep is not as disrupted. So she thinks that you're the bee's knees of menopause doctors, which is fabulous. And she started telling all of her friends how wonderful you are. And just to make yourself feel really, really good, you do another symptom scoring sheet, and you've made a huge reduction in her symptoms from 18 to 8. Now, we mentioned this before, Mirena management at this time of life can be a little bit nuanced, and the most important thing to take away from this slide, though, that is if you are using the Mirena for endometrial protection as part of your MHT, that it can only last for 5 years because the evidence is only there for that 5 years. We've talked about the fact that, yes, you can extended use it for contraception if that's all you're using it for. And we talked already a little bit about if you've got amenorrhea with the Mirena and you're using it for contraception, when do we think about removing that Mirena? So, like I said, Kate was super duper happy with you. And so she's told all her friends. And now Tina's come in at the recommendation of Kate. Tina's 49, and she's really struggling with vasomotor symptoms. She's getting hot flushes and night sweats. She's waking 5 to 6 times at night, and she's having to change the bedding kind of multiple times a week because she's soaking through. Her periods are irregular, but they're not bothersome the same way Kate's are. And she thinks that's been for at least a year, and she actually hasn't had a period for about 5 months. She's noticing that she's increasingly anxious and tearful, and she's having memory problems at work. Contraception isn't an issue for Tina because she's had a vasectomy, and she's trying to stay fit and active. She's running, doing a park run every Saturday and cycling to work, but this is becoming harder and harder. Generally, otherwise, she's pretty fit and well. she's not a smoker, she doesn't drink, blood pressure's great, BMI is in a normal range. But because she's been so well, she can't really remember doing any screening tests. But she has been having this problem, and she did see another doctor, and they did some bloods for her, and they told her that the tests were all normal and it wasn't menopause. Which made her feel pretty invalidated. By the time she comes to you, she's feeling like a little bit like a crazy person. But obviously, as Claire discussed before, the menopausal transition is a clinical diagnosis, and those blood tests did not tell Tina that she was not in menopause. So this is where Tina is sitting on the straw criteria. She's starting to get those really big gaps in her periods, and so she's sitting in that late menopausal transition, and we're starting to get an increase in those vasomotor symptoms, which we often see in that late perimenopause and early postmenopausal periods. Mental health and the perimenopause. This is a really difficult space. And I think as GPs, you guys do this all the time, and are probably better at managing it than we are. And you've probably already seen in your patients going through the menopausal transition that it is a real time of vulnerability. And so we know definitely our patients who have a past history of depression experience a 5-time increase in their depressive symptoms, but we also see a significant increase in depressive symptoms with those people who have no history of depression. And I think this statement, you know, perimenopause symptoms complicate co-occurrent overlap with the presentation of depression is very true. And it does make it difficult to separate and decide what we approach first. Obviously, the things that are proven to help in depression are antidepressants and psychological therapy. And I think definitely for patients who have major depressive episodes, particularly with past histories of the same, these probably still do remain first line, but definitely aren't the only things we necessarily use. The points on this slide come from one of the psychiatrists that works in this menopausal space, and I think they're a good guide of how we might think about it. I wouldn't consider the points as absolutes because we know that often our patients are actually combinations of these, but definitely those patients, like I was saying, who have a past history of major depressive disorders, I think most of us would start with using what worked for previous episodes. Our women that are sensitive to hormone withdrawal, and so those are our patients with things like PMDD or maybe some postnatal depression in the past. They can be difficult patients to manage. They often do respond well to MHT, but sometimes it can be a little bit nuanced getting the regime right. Some of them will struggle, particularly if they present in perimenopause, with cyclical treatment, and so there might be a little bit more tailoring for those patients. Definitely our women who are struggling with their mood and are getting really severe sleep disruption secondary to hot flushes and vasomotor symptoms. A lot of them do stand to benefit quite significantly with MHT, and obviously that can be alone, but it also obviously can be in conjunction with medications or psychological support. And I would say probably all of us need a psychologist, but particularly with significant life stresses, which a lot of our patients at this stage of life are struggling with, it can be a big help if you can convince patients to engage with them. I'm not going to go over this too much because I think actually as GPs, most of you guys are pretty on top of how to manage mood. I will just draw your attention to the fact that there is a separate scoring sheet that you can use for for mood symptoms in menopause called the MenoD, which I believe, I don't know if we're going to have links to, but Claire nods to me that we are going to send you links to. And so this is the symptom scoring sheet that Tina fills in, and obviously she's scoring quite high, and we're getting lots of those vasomotor symptoms, including the hot flushes, some secondary lightheaded stuff, that feeling of crawling under the skin, and lots of sleeplessness, and secondary mood changes as well. So things to consider for Tina's consult, like I was talking about before, I think education for these patients is really, really important for Tina, so she can understand and guide her way through this. There are also some additional resources that you can get on the Australian Menopause Society about for employers about menopause in the workplace. So that might be something useful in this scenario. I think you're all very on top of the fact that this is going to be a great opportunity for midlife screening and lifestyle interventions. But mostly what Tina's come to you for as a great menopause doctor is treatment options for her symptoms. And so coming back to this flow diagram again, Tina is still in the same pathway of having her uterus intact, but being less than 12 months since her last menstrual period. And she's still got the same options as Kate, but obviously she's got a little bit of a different set of priorities. She doesn't need period management specifically, and she already has contraception. And so we've got a little bit more options there for Tina. And so at the end of this first consult, once again, Tina was really smart and booked a long consult. So you managed to get some time, as well as listening and validating Tina, to get in some education, and making that really important point to Tina that our diagnosis of the menopausal transition is based on symptoms and not a blood test. And you link her in to some additional resources. She is due for screening, both for her cervical screening and mammogram, and I think these are important things to get done. And she says to you she wants the most low-cost but effective treatment. And so you talk her through what her options are, and that includes cyclical MHT, estrogen plus the Mirena, or a low-dose oral contraceptive pill, given that she is under 50, with no other significant risk factors that contraindicate its use. And you also are super efficient and talk a little bit about lifestyle, and particularly adding in some resistance training for Tina. So Tina returns to come back to look at her results and talk a little bit more about treatment. And her results all look good, and she doesn't have any contraindications to MHT. And she's decided, after you've educated her really well and she's read through the resources that you've given her about risks in MHT, that she would like to try transdermal MHT to decrease particularly that blood clotting risk. And so you talk about a couple of different options, including using a combination patch, which is a starless sequi, which only comes in a mid-dose strength, and also about whether or not we use a combination of estradiol and micronized progesterone. And you decide that you will review her in 6 to 8 weeks to see how that's going. So this is coming back to that great Australian Menopause Society dose equivalent resource, which I think I look at several times a day. And this is what you're going to talk her through in terms of her available options. She ends up deciding that she's going to do some transdermal continuous estrogen and cyclical progesterone in the form of a starless sequi. Now for Tina, because her periods are having really long gaps, she will probably just start it at any time. But if her periods were predictable, you'd probably aim to start on day 1 of the cycle with the estrogen-only patch to try and fit in with that cycle as best as we can. You're going to tell Tina that you're going to change the patch every 3.5 days. And a common regime women might choose is Monday morning and Thursday evening. And you're going to talk to her about applying it to the thighs, lower abdomen or buttocks, but that there are a couple of places and times that we would try and avoid. You can tell Tina that she can reapply the patches if they do fall off, but if they don't stick, she does need a new patch. And once again, Tina comes back to you and is feeling really happy, and she's going to tell even more friends how wonderful you are. She's getting a regular withdrawal bleed in that 2 weeks when she ceases the progesterone, but she was informed of that by you and she's happy with that. She's not getting any side effects in terms of breast symptoms or headache or nausea, and she's very keen to continue with her current MHT regime. And so you tell Tina that actually we can review her in another 6 months, but you put some safety netting in place and tell her if she gets any unscheduled bleeding or breast symptoms or any other concerns, she should come back sooner. And this is once again, you repeat her symptom scorer and feel really good about the fact that you've made her feel a whole heap better. Now, so, Tina's going to stay on this cyclical MHT, and the question she will probably ask you, because she might get a little bit sick of having her periods, is when can she switch over to continuous MHT? So the guidelines would suggest that it is reasonable to trial a patient who's been on cyclical MHT for 12 months onto a continuous preparation. I guess the only caveat to that is we are seeing patients earlier and earlier and starting them on MHT earlier. And I do find, and I suspect Claire finds the same thing, that some of our patients in earlier perimenopause probably don't tolerate that switchover at that 12-month mark. But ultimately, it's a trial. And if they do get breakthrough bleeding, they do need to go back to cyclical for another year. Because as Claire was talking about before, it's very difficult to tell the difference between breakthrough bleeding due to their MHT and abnormal breakthrough bleeding. And so we try and avoid it if possible. I'm sure you guys have all heard about bioidentical compounded hormones. And so this is just a quick reminder that the evidence is lacking for their safety and efficacy. And all of the major international menopause societies have major warnings about the use of bioidentical compounded hormones. In particular, the bioidentical compounded progestogens, which are there to try and protect the lining of our uterus, do not have evidence to back up that they are effective at this. And there is a good chance that they may not protect the endometrium and place our patients at that increased risk of endometrial hyperplasia and cancer. Now, I'm just mindful of time, so I might go a little bit quicker through these last couple of cases. So this next case is Susie. She's 51 years, and she just comes in and sits down and says she needs something done straight away, and that she's tried everything, and it's all cost her a small fortune, and she needs something done now. Her last period was 14 months ago, and she's got vasomotor symptoms and sleep disturbance, and she's also got a dry vagina and a lot of pain during sex. She lives with her husband, who's had a vasectomy, and she's got 2 adult children. She does smoke and drinks 1 glass of alcohol per night. She doesn't have any other diagnosed medical problems, but does have a strong family history of metabolic conditions and is relatively sedentary with a bit of a slightly upper limit of normal blood pressure and a slightly raised BMI. And of course, Susie has presented with a 15-minute appointment, and she would like everything done today. And so we have all had these patients. I've definitely had some of them. And you know, the moment Susie sits down, this is going to be a bit of a hard consult. And I think coming back to what we were saying before, setting those expectations whilst validating the patient and their symptoms, and validating that it is important that she does come back, but doing good quality menopause management does require time. Sometimes having telehealth consultations can help for a stressed person who is struggling to fit things in with their lives, and particularly if you've managed to do, you know, the basic stuff that you need to do in the first consult face to face. Telehealth can work really well. So coming back to those top 3 things that the patient wants to get addressed, definitely for this patient, you want to make sure that we've updated her screening and that we're happy with it, because she does have a couple of risk factors there. And coming back again to the fact that we do not need hormone levels to diagnose menopause. So for this patient, we've got very severe vasomotor symptoms and sleep disturbances and genitourinary symptoms, and a number of kind of concerning signs in our lifestyle management. So lots to cover. So genitourinary symptoms of the menopause, which was previously known as atrophic vaginitis or vaginal atrophy, which I think has been a really positive name change for patients. And so we know that we have estrogen receptors throughout our vagina and urethra, bladder, and pelvic floor muscles, and that these changes result in vaginal dryness, loss of lubrication with sex, painful sex and bleeding after sex, and also urinary symptoms in terms of frequency, urgency, and increased UTIs, and vulval symptoms as well. And it can be really quite debilitating for patients. Sexual wellbeing is obviously really complicated, and I feel like we could probably do a whole talk on sexual wellbeing in menopause. And we know that the genitourinary symptoms of menopause are really, really very common, as Claire was talking about, and very significantly undertreated. They are the symptoms that tend to happen later, and for most women don't go away, unlike the vasomotor symptoms. But the good news is we have good effective treatments that are very safe. Our vaginal estrogens are very safe and can be used in addition to systemic MHT, and for a lot of patients that is needed to get their symptoms, their genitourinary symptoms, under good control. There are also non-hormonal options in terms of vaginal moisturizers and using lubrication during sex. But obviously vaginal estrogens, for those who can use them, are the most effective. So these are the products that we have available for vaginal estrogen in Australia. We've got Avestin, which is in a cream and a pessary, and the Vagifem Low. We need to do a introductory dose of nightly for 2 or 3 weeks, and then we adjust the dose depending on symptoms. And I usually tell patients that probably commonly most people will end up using it 2 to 3 times a week, but that they should try and aim that towards what manages their symptoms well. You do need to warn them a little bit about the product information, which is, it refers to the risks of systemic MHT, and we know that actually vaginal estrogen does not confer those same risks as systemic MHT, and it's actually very safe. This little picture here is to remind me that vaginal estrogen is a really good start for those women who come in complaining of loss of libido. I don't think anybody who's having painful sex looks forward to having sex. And it's often a really good first step for those patients that come in quite distressed about multiple symptoms and feel like they need to have something that they can take away, but you often don't feel ready to give them systemic MHT because there's a lot of things in terms of investigations that you want to arrange. This is often a really good thing to give to start off with, to get them started on something whilst you're doing some investigations and you're also getting them to go away and have a read about the risks and different options. And so that's exactly what we do with Susie. We give her some vaginal estrogen cream, some Avestin, and she uses that for 2 or 3 weeks every night, and then drops it down to twice weekly. And then she returns at 5 weeks, and she's much happier and is now a patient that's in much less crisis because she's actually able to connect with her husband, and feels like we're at least starting to get some of her symptoms managed. She's done some of the reading that you've given her about menopause and how her lifestyle affects her menopausal symptoms, as well as about MHT. And in response to that, she has actually reduced her alcohol intake, which is great, to only 2 units on weekends. And she started increasing her exercise and is already just feeling a little bit better in herself as a result. She does still have her bothersome vasomotor symptoms. And so this is where Susie sits in the stages of reproductive aging, and she's in that early postmenopausal phase, which is where we often expect the most significant vasomotor symptoms. She is 14 months, like we talked about before, and so that's why we're putting her there. And so she is now our patient that is able to consider a continuous MHT regime in the first instance. And so we've got low or medium dose transdermal estrogen plus progestogen, or oral. And we can also do topical or oral estrogen plus the Mirena. We can do oral estrogen and a SERM, tibolone, or also non-hormonal menopausal therapy. Now, Susie is really keen to go with something effective, but she also wants the safest choice. And so, as Claire was talking about, that's looking at an estrogen that looks like the same estrogen in our body, so something like estradiol or estroderm, and progesterone, microdosed progesterone, and so that's what we trial. Usually, you can get Susie back at about somewhere between 6 weeks and 12 weeks for that initial review, and then we get her back once every 6 to 12 months. And so that's again where we are on that that flow diagram and the options available to Susie. And that's just another review of that great AMS resource. And so Susie is very concerned around, she's starting on this MHT and she wants to know how long she should use it for. And I think this is probably something that the messaging around this has probably changed a lot over the last decade or so. And I know that, kind of 10 years ago, we were throwing around that kind of 5-year maximum. But helpfully, the research has come a long way, and now most of the guidelines agree that there is no set minimum or maximum duration for using MHT. It's important that MHT is taken to alleviate the symptoms of menopause, and so that's what we should tailor the duration to, whilst considering that risk-benefit analysis. We do aim for people to be on the lowest effective dose, and having that assessment once a year allows you to keep reviewing that risk-benefit analysis by making sure that you review their symptoms, what dose they're on, and whether there's been any change in their medical history. But this is a really individualised process. Bleeding on MHT, particularly when we start continuous, is not uncommon, which I'm sure a lot of you have come across. And in general, the rule of thumb is if we're getting bleeding after 6 months, that it should be investigated. I will say that there is sometimes some patients that have a lot of risk factors for endometrial hyperplasia or cancer that we might investigate earlier. But 6 months is a good general rule of thumb for most patients. Once you have investigated, you might consider making some changes to try and manage that bleeding and see if we can get it to settle. And that might be changing or increasing the progestogen, the Mirena, or if you're using microdosed continuous progesterone, changing it to 25 days a month rather than the full month, which still does provide you with a good baseline of endometrial protection. How am I going for time, guys? We're probably running. Sorry?
Yeah, I think we'd love to have your last case, but maybe we'll just zoom through it.
I might zoom through it, and I might actually just cover the points rather than go too much through this case. So Jane is probably a little bit of an easier case. She doesn't have a uterus. And so she's just here to remind us that our patients without a uterus that don't have other risk factors like endometriosis can just use estrogen only, and that is very appropriate for them. And this is the AMS, like we thought about. Memory and brain fog, really common complaint particularly in perimenopause. And there's lots of good research to say that this is a real thing, and that cognition, particularly verbal learning and verbal memory, are particularly affected. And look, there's probably a number of things that do contribute, particularly hot flushes with sleep disturbance and also mood changes such as depression, probably all are major contributors. And addressing those sometimes can help. I think the most important message to get across to patients, though, is who often feel like they actually are, starting on the early stages of dementia, is that the menopause memory problems are time limited, and the memory does improve after menopause. Brief slide on tibolone, because we often have lots of questions about tibolone. So tibolone is a synthetic oral steroid that affects the estrogen, progestogen, and androgen receptors. It's considered a low-dose MHT, and it has the same contraindication as conventional MHT. I know that initially when tibolone came out, there was lots of excitement about it in terms of its improvement in libido, and that hasn't been well proven in the literature, and so we don't necessarily use it for that. There was some evidence suggesting it did have an improvement in sexual function, but that didn't go head-to-head with standard MHT, and probably the effect of that is the same as MHT. We only use tibolone postmenopausally, so more than 12 months post their last menstrual period. And there was a little bit of evidence around stroke risk in older women. So this is our menopause toolkit, which I believe CHM will be sending out to you guys. So don't worry about the fine details. You'll all get a copy. But I think having this really helps. And having a number of these things printed out for you for your menopause consults makes a really big difference. So that was our last case. A couple of quick points about traps and misconceptions, which I think we've already covered, but just to summarise them. Trying to attempt menopause in a 15-minute consult is hard. And working in general practice, I understand that's often how our patients present. But valuing that this is something that's really difficult to do in that time, and booking the patient a couple of long consults makes the world of difference. And we're all very clear that we don't need hormone blood tests to diagnose menopause, but often we get requests for it. And so working out a way to do that and manage it. And also managing those requests for bioidentical hormone prescriptions. Our fourth point, I hope that that no one will be doing after this talk, telling women that it's all normal and they should just wait and it will all be okay soon, which I think probably happened a lot back after that initial Women's Health Initiative study came out, but I think we've come a long way since then. And definitely we know that we don't have to wait until after our periods have stopped to start MHT. I think remembering that we don't need to arbitrarily stop MHT after a set duration, that the decision to continue MHT is based on if it's required for symptoms and on an individualised risk-benefit assessment. And that we don't need to deny MHT to women with a family history of breast cancer. And our last point, I think, is leading into our next talk. But we also want to avoid telling women after breast cancer there's nothing that can be done about their menopause symptoms. So our last take-home messages, I hope you all feel very invigorated and confident now in starting on some menopause management if you are not doing it already, and that you will have the menopause toolkit to help guide you if you do. And as you're all aware, midlife care provides this great window of opportunity for chronic disease prevention, and it is really greatly rewarding. And I think particularly our menopausal patients who struggle with their symptoms and often have been very invalidated really appreciate the care that you're able to give them.
Thank you very, very much. That was really great. So Claire's been very busy beavering away in the background while Tara's been speaking, answering all the questions on the Q&A that we usually have at the end of the session. So a lot of the questions have been answered. I thought I would just repeat one that Claire's just answered about giving menopausal hormone therapy for menopausal women who don't have symptoms, but for cardiovascular health and osteoporosis. And Claire said that currently it's not indicated. So it's not indicated for osteoporosis prevention, although there's ongoing research. And I'm sure if you had a woman in between the, in the perimenopause or the menopause, you would be able to scratch around and find some of those symptoms on the menopause chart because I'm sure you could find them. And we've got another question that's just appeared, and oh, sorry, I have to start my video. Here we go. Sorry. There we go. That's me. Oh, I'm looking a bit dark. There I am. How do you manage a request for a menopausal hormonal therapy script from a woman in her, it says late 60s, but let's say in her 60s, who wants to continue it long term? So late 60s, long term.
So this is a really tricky consult to do, but if she has been on hormone therapy since an appropriate time, so she started around her menopause, I wouldn't arbitrarily stop it. Certainly there are some women in their 60s and even in their 70s who have significant vasomotor symptoms when they try to stop their menopause hormone therapy. But I would have the conversation with her around what are the risks and talking particularly about the breast cancer risk. I would also try and make sure she's on the safest regimen that's available. So I'd be looking for a transdermal estrogen and micronized progesterone if she can afford that. If she can't, if that is a too expensive option for her, in terms of breast health and oral therapies, the next best progestogen to use is digesterone. So this is the progestogen that is in Femostin Conti, and that's a low dose hormone preparation. But it is a difficult conversation to have. But again, I think there's no absolutes, and I think we give the women the information about what we know about the risks and what the benefits are. And provided they can make an informed decision, then I think it is reasonable to continue hormone therapy. What I wouldn't do is initiate hormone therapy for someone who's in her 60s, because the danger there is that she's got some plaque built up in her arteries, and we then give estrogen, and we are more likely to cause stroke and a heart attack.
That's good advice. Thank you. I had a question about the pervaginal estrogens. To what extent do they cause any endometrial kind of proliferation, and do you need to do any endometrial monitoring if people are on them long term?
No, you don't.
That's good. Okay.
Yep.
Excellent answer. A short and sweet one.
But any postmenopausal bleeding, you need to investigate.
Right. Yep. Also, on the packets for some of them, like for the perimetrium or the micronized progesterone, they've got the recommended doses for cyclical 12 out of 28 days for the cyclical, and 25 out of 28 days for the continuous. But a lot of the menopause experts kind of say take it for 14 days or take it for 28 days. Is that just because it's a simpler regime to remember?
Yep. Yeah.
Yeah.
There's a little bit of evidence that the 25 out of the 28 for continuous gives better control of bleeding, but it's just impossible. And if you think that most women will probably forget 1 or 2 progesterone tablets in a month anyway, or capsules in a month, that actually saying take it every day or for 2 weeks on, 2 weeks off is much easier to remember.
Right. Yeah. And what about people on the cyclical progesterone and they don't get a withdrawal bleed, even if it's within 12 months of their period, is that okay?
Yeah.
Yep.
Yeah. So the lack of
it often happens that the periods get lighter as they get closer to the actual menopause. Yeah.
Yep. Okay. So sorry to bombard you with questions. I had told you I had a few myself. We better wrap it up. We're 2 minutes short of 8 o'clock and people probably need to get on with their night. So thank you so much. That was a fabulous webinar and very, very useful. Just to let everyone know, we're going to put it up on our Capital Health Network YouTube page in about 2 weeks. So if you want to have a look at it again, or if you want to share it with other people, then it'll be there for you. And thank you so much to Claire and to Tara. And we'll be sending out the evaluation surveys shortly, so please return them. And we'll also send you out your certificate of attendance so that you can register your CPD on your CPD home. And we'll have the second webinar in early 2024. I'm sure it'll be very popular. This one's been very, very popular as well. And we'll send out an invitation closer to the event. So thank you very much to the presenters and to everyone who's attended. Thanks. Bye.
Thanks, Leonie.
Thanks, Leonie.
Thanks.